It's live now, Chris.
Okay, thank you. Welcome everyone to the first of our live streamed primary care clinical commissioning committee, and just wanted to make sure that we have we have had some technical problems, so just starting with a few apologies, but I should be okay at the moment. First of all, apologies. We had apologies from voting members of Leslie Smith, Alan Windell, although Danny Height is here for Alan, Brian Hughes, and apologies from non-voting members of Nikki Bates, Sarah Burt and Zach McMurray. And from people normally in attendance, apologies from Greg Fell. So Jackie, we are quorate at the moment, aren't we, for this public meeting?
We are, and just to note, we are expecting Amir Afsal to join us, but he hasn't actually joined us as yet. And
I think we're also expecting Judy Thorley to join us. I don't know if she's joined us so far. She has. Thank you. She was going to be a bit late, but I think my technical problems have sorted that one out. Okay, then, if we can then go to the agenda and any declarations of interest from people taking part in the meeting that haven't already been declared. If you could speak up. There isn't any. Jackie's saying there isn't any, so that's fine. We have had a question from a member of the public, which is to do with cardiac rehab. However, we won't take it at this meeting because it's not within our remit, but it will be taken at the governing body meeting. So if we can then go to the next item, which is approval of the minutes from last time. Thank you. So if we can look first of all then at sorry, I'm just finding mine on the computer. If we can look then at page 1 of the minutes from the public meeting. Anything on page 2? Page 3? Page 4? Page 5? Thank you. If you could just, I'm just getting this document up. Again, some technical problems. Mark, if you could just go through the last bit of the notes for an accurate record.
Mute.
Any comments on page 6? 7? Okay, so in terms of accepting, are we agreed to accept these minutes as an accurate record? I'm getting nods. Fine. Okay, so we now move on to matters arising.
Okay, I've got those, Mark.
Fine.
So first of all, item 2921, which is about declarations of interest and about the LMC for completion. And that is still open, and a declaration of interest form to be sent to the LMC for completion. Abby, where are we at with that? Do we need to have it on the next agenda?
Chris, it's Ronnie. I've sent the declarations of interest to LMC and I've received them back yesterday, so they're just being processed. So that could be closed, that item. Okay,
thank you. The next item, which is open, is the Abbey Lane surgery in Totley Rise Medical Practice. Ms. Tebbs and Linda will discuss this again once the data has been received, and also that we have the EDEC results. I think then we need to look at, I think they've just recently come in, Abby, is that correct? And therefore we need to look at it when we've had a chance to have a look at it. So we need to keep that on the agenda for next time.
We'll bring back the conclusions to both the discussion and the analysis of the data, hopefully to the September meeting.
Okay, thank you. Then we have a number of items for closure, some of which are on the agenda. So the first one is the primary care financial outturns, which is on this agenda. The progression of the PCC meetings in public and engaging members of the public. And we were going to discuss if we should live stream it at this meeting. We decided just to go ahead with it. We've had meetings in public, which meant all the papers are available. So we're going ahead with it. Not a great technical start from myself, I must say. The next item was a triage into primary care. And we've included future PCC development session. So it's been included in the development sessions that we're having. So we're recommending that for closure. Okay. So are there any other matters arising that haven't been identified?
Chair, can I just say that in case you can't see this, that Dr. Afzal is now here.
Okay, thank you. Can we make sure that that's noted in the attendance? I can't see it now.
So, apologies, Chair. I was a little late.
No, that's fine. We did know that you might be late. Thank you. Okay, then. So if we can go on to the papers for approval. So the first item is the retained GP scheme, which we have discussed at previous meetings, but Abby is just going to introduce this paper. So I can hand over to Abby.
Thank you very much. I'm Abigail Tebbs. I am Deputy Director of Delivery for Primary Care at the CCG. Yes, as you said, Chair, we have discussed the National GP Retention Scheme on many occasions. At the last discussion, the committee agreed to implement a process whereby applicants for whom we had no available budget would be offered an opportunity to join a waiting list that we would maintain, and then when budget became available, we would contact those applicants in order of them joining the scheme to understand if they were still interested in taking up a place. We have now received a further application for 2.25 sessions a week. The position on the retained GP scheme remains as previously. We have 4 GPs currently on the scheme, and the budget the CCG identified to meet the costs of the scheme in 2018 is fully committed. And therefore, the recommendation to the committee is that we decline the application, or we inform them we're not able to offer them a place on the retained GP scheme in Sheffield, but we do contact the individual and the practice and understand if they would like to join the waiting list, which currently has 1 individual on it.
Okay, thank you, Abby. Yes, so although this is a national scheme, there isn't any national resource for this. So we've identified a budget for it, but it is already oversubscribed, as you can see. But we did agree to make note of any applications and let the practice know that if the resource became available when somebody perhaps leaves the previous scheme. It's also really important to us, the primary care capacity, and particularly the pressures at the moment. So there are a number of other things that we're doing alongside this with regard to GP capacity. Can I ask if there are any questions or any other points to be made? If you've got your hand up, can you speak as well? I can't see any hands up from what I've looked at.
I don't think there are any hands, Chris.
No, okay, thank you. So the recommendation is that we approve this paper and the proposal that we decline this application at the moment because there isn't the funding there. So if we can agree that and then move on to the next item, which is approval of the H1, which is the first half of the year, and also for the budget, and then also for the financial position at month 3. So if I can hand over to Jackie for that, please.
Thank you, Chris. So I'm Jackie Mills, I'm Director of Finance. I'll just pull out the key points that I would like the committee to note in terms of this paper. So as noted in the paper, the purpose of the item is to seek formal approval of the initial budgets for primary care for the first 6 months of the financial year. And that's referred to as half 1 or H1, as Chris has identified. And you'll recall the reason that we are only approving a budget for the first 6 months is that is the time period for which we have been allocated resources from NHS England. We are still unclear of the arrangements for the second half of the year, although it does look like the current arrangements will roll forward to the second half of the year, but with a lower level of resources because of the expectation that efficiency in the second half of the year will improve. And then the second part of the paper is just to note the updated financial position is at the end of June. So members will recall that the budgets for primary care were initially presented for consideration in the paper to PCC on the 13th of May. However, because that indicated a significant level of financial overcommitment, I did want further time to test some of those assumptions and also to identify potential mitigations to manage the position before I brought these to the committee for formal approval. And whilst I can report that that further work has been undertaken, unfortunately, this has not resulted in a substantial reduction in the required budgets. And it's would still indicate that the recurrent expenditure is running at approximately £1 million higher than the delegated primary care allocation for the first 6 months. And that would obviously extrapolate to something nearer 2 million for the whole financial year. Members will also note that this level of overcommitment is a continuation to what we reported in the previous financial year, although that has been further exacerbated by additional cost pressures, and those are outlined in the paper. So in considering what to recommend to the committee, I've reflected on three things. One, whether there are potential mitigations that might make the position more manageable in the short term. Secondly, how the forecast position on primary care budget sits within the CCG's overall financial position. And then finally, whether the longer term financial position is sustainable, and that's both in terms of primary care and the wider CCG position. So what I am recommending to the committee today is that these budgets are approved, but with the inclusion of a negative budget line to bring the overall budget back in line with the overall resources. And I'm recommending this for the following reasons. As I've noted in the paper, there are some potential mitigations to manage the position in the short term. The majority of those are likely to be non-recurrent, but they are, I think they are realistic in terms of helping to manage the position in the short term. And those mitigations also sit alongside an assessment of other risks and mitigations within the wider CCG financial position. And whilst there are still a wide range of issues, and given where we are in the financial year, we are working on limited information, but my current assessment is that based on the information available, the overall financial position for the CCG is manageable over the first 6 months. And the final issue that I've considered is that in the longer term, you will note that the level of recurrent overcommitment is increasing year on year, which is clearly not sustainable and ultimately will not be fixed by just using short-term slippage. It will need to be addressed. But in light of the continued uncertainty regarding funding arrangements, both for the second half of the year and beyond, and in light of the multiple pressures on primary care at the current time, I don't think it's the right time to be able to robustly examine options for managing the position. I'm therefore recommending that we should avoid any additional recurrent commitments and should continue to test that current spend represents good value for money, but that we should adopt the current budgets as outlined in the paper. So they were the key points I just wanted to draw out clearly. As I note in the paper, the month 3 position is still showing a level of overspend, but I am hopeful that as over the coming weeks and months, we'll be able to identify and quantify some of the issues that I've put in as mitigations into the paper. So I'm asking the committee to approve the budgets and note the financial position as at the end of June.
Okay, thank you, Jackie. I know Mark has got his hand up. Do you want to go ahead, Mark?
Thanks. Yes, Mark Gamso, I'm a lay member on the Clinical Commissioning Group. I just wonder, there's a very helpful paragraph in here, Jackie, when you talk about there's a range of pressures here that have created this situation, and you give a bit more detail about the locum pressure later on in the report, which is clearly, if I understand this correctly, is clearly a significant contributor to that sort of change in position from the one you outlined earlier. I suppose the question I had was, and I'm particularly concerned by that, and also the historic forecast deficit as a result of historic contract uplifts. So both of those things seem to be things that you would have thought NHS England might be concerned about. I mean, one is historic, and the other is locum cover due to COVID, in particular, I assume, and therefore you would have thought that this is something that NHS England might be talking to the Department of Health about. I don't know whether you're in a position or Victoria is in a position to advise us about whether there's the potential in the future for anything to emerge there. And just as part of that, I did wonder how these pressures compare to our sister, whatever we're allowed, what would we call them, CCGs or places in South Yorkshire and Bassetlaw at the moment.
Okay. I'm happy to pick that up. Victoria can contribute if she feels I haven't covered everything. In terms of the locum issue, we have received additional funding to cover COVID expenditure from NHS England. We have identified that to commission additional hub capacity to support primary care capacity, so we haven't used it to fund the locum pressure. And you'll note that the level of funding this year is lower than we received last year, and is set to reduce even further. So I haven't used the COVID expenditure funding to fund this particular pressure, because there'd be insufficient funding available anyway. We're struggling to contain costs within that additional. In terms of whether this is consistent with what is being felt in other CCGs, I don't know the answer to that, but it is a useful suggestion. I will go and compare our locum spend. The majority of the increase was linked to sickness, but we have seen increasing numbers of claims for maternity as well. And I think there is a general trend in terms of maternity following the last 16 months. So I think there may still be ongoing pressures in terms of locums. It is too early to see what the forecast is. I'm hoping it will drop back, but we know that, certainly anecdotally, I know of a number of GPs that have been off for a significant amount of time linked to long COVID. It is a matter of time to see how quickly that will fall off. In terms of the general cost pressures from the fact that our primary care allocation uplift is less than the contract uplift, that is more to do with our current position against the resource allocation and our distance from target. So it is differentially felt across CCGs depending on what their primary care uplift is. So because our primary care uplift is lower than the national average, it does give us inherent pressures when we have to fund the national GP contract uplift.
Thanks, Jackie. Got Judy has got a hand up. Was that somebody else speaking now? Is that you, Judy?
Sorry, I was just clarifying whether that covered the answers to Mark's questions.
Okay. Mark, is that okay? Is that covered what you wanted?
Yeah, that's helpful. Thank you.
So, Judy, did you want to go next?
Yeah, thank you. I just wondered, Jackie, no doubt you have regular discussions with colleagues at NHSE as regards the budget and the difficulties, but I wonder if there's any value in this committee requesting that formally write to them in our continued concern, given that I know the issue in terms of allocation is historic, and there's many CCGs that have that, but the locum issue, for example, and others, there's some specific things that we might want to highlight as ongoing concern.
Yeah, so it's actually Abby who has the joy of trying to manage multiple pressures. So Abby, I'm wondering whether that is something worth picking up at the primary care programme board to test whether there are similar issues in other areas and whether there's a joint solution to that. I think what is increasingly becoming apparent over the recent weeks is actually the ability to obtain locums is becoming increasingly challenging. So it might be that we swap one problem for another. We might swap the financial pressure for a capacity pressure. So it is something that is quite a live conversation at the moment.
Thank you, Jackie. Amir?
Come in at that point as well, Chris.
Apologies. What did you say, Jackie?
At that point.
Okay, thank you.
Do you want to?
Just very briefly to say that that yes, some of the pressures on primary care, and the general demand and workforce issues are not unique to Sheffield, and we do discuss them already, and have actually had a conversation in the last week or so around what other I've had a conversation with other primary care leads in South Yorkshire and Bassett Law about what other CCGs are doing or might be doing to support practices. As an ICS, there are two things. One is around we have resilience funding from NHS England, and we have some recruitment and retention funding as well. And primary care leads have been tasked by the ICS Primary Care Steering Board with coming up with a proposal on how we use that to best effect this year. And also just to note that we are seeing, as Jackie said, we are seeing increasing absences in primary care. They may not be of sort of significant enough duration to sort of trigger the locum reimbursement, but they're due in part to the increasing number of cases of COVID and people getting picked up by the NHS app and asked to self-isolate or test and trace, and being asked to self-isolate because they've been in contact with another individual, and that is having a significant impact on practices at the moment.
Okay, thank you, Abby. Amir?
Yes, very relevant to both the points that Jackie was talking about and Abigail. Really, oh, I'm sorry, I'm Amir Afzal, I'm a GP on the CCG. The nuance in all this is, and with my appraisal cap on as well as the locality GP, is this is the time of the year the GPs would have traditionally recuperated a little bit. And, only yesterday I appraised a colleague who's got 2 GPs off, 2 partner practice, 1 salaried. The salaried and the partner are off. She's doing 12 to 14 hours a day. And before long, it'll be September again. So I think this is very, very real. And it's almost kind of at breaking point. The thing that I wanted to ask Jackie was whether we've any kind of figures at all, because as GPs, and certainly in primary care generally, but GPs in particular, we're very, very bad at recording this kind of stuff. I took a long time speaking to this colleague, kind of saying that, and she was on a downward spiral, because as well as I do that what often happens is that somebody goes off, you work, time and a half, etc., and before you know it, you're going to end up on your backside, and where do we go then? So it would be nice to actually have some facts and figures. I don't know how we kind of go about that. And incidentally, with the collection of the data, they're going to start picking off the GP computer systems. I've just readjusted my practice, and I'm getting a similar story from everybody else. And when I've actually put down the appointments and the clinical admin time and the face-to-face and the telephone, etc., I'm surprised that almost at the age of 60, I'm still double and tripling what I'm doing in a day. So I'm actually sat here having my dinner, doing my, medication reviews, answering the phone calls. All that activity traditionally never got recorded. So maybe that will give us an allied kind of idea as to the activity. But in terms of numbers, you're absolutely right, Jackie. I think we're going to hit both things. We're going to hit lack of bodies, and we're going to hit people being absent from practices. And finally, the other trend that I'm beginning to see is people are leaving to go and do salaried or hub work, which is very specific amounts of time that allows them to have the freedom of work or not to work. But that's leaving the core GMS in hours terribly, terribly depleted. Just some reflections from the front line, really.
Thanks, Amir. I know that quite rightly you've raised that issue before, as well as the helpful suggestion of how do we collect what is actually happening at the moment. And I think certainly at our last meeting, we decided, as well as a development session about primary care capacity in the workforce, we also wanted it to add, to the meeting agenda as well. Abby, is there anything that you wanted to respond to with regard to the issues Amir's raised?
I think there are very, very live issues at the moment, and they are forming probably at this moment in time one of, if not the primary focus of the CCG, in terms of how we address that pressure in primary care and the rest of the system as well, because as we know that as COVID infections are increasing, hospital admissions are increasing, and AE and attendances are increasing. But I think the primary recognition of the ACP system at the moment is that urgent primary care is a priority, and if we can't support primary care, then that will have huge impact on the rest of the health and social care system in Sheffield. And that is the focus of certainly the people here. The focus of most of our work at present is to identify ways that we can support both short and long term, offers both short and longer term support to primary care. Jackie, sorry.
Chris, sorry, before you bring Mark in, just I think in terms of responding to Amir's ask around data, Abby and I have had a conversation about the workforce reporting within the primary care dashboard. So we have agreed that we'll look a bit further, and we can probably put locum sickness rates into that report as well. So I think if we note that Abby and I will take that action forward through the primary care dashboard.
Okay, that's a useful suggestion, thank you. So I've got Mark and David. I don't know who put the hand up first. Mark, do you want to go next?
Yeah, please. I'll try to keep it brief. Endorse everything that Amir has said. It's a massive crisis, but then again, with a sense of deja vu, this committee and the governing body have debated this issue many, many times. And we've just reflected on our inability to support any posts in the retainer scheme. And I believe in your opening remarks, Chair, you alluded there were other things happening to support resilience in primary care. I was just interested in what those were.
Okay, Abby or Jackie, did you want to respond to that before I move on to David?
Certainly, I think I mentioned as part of the response to this item that we have an allocation of local ICS level funding from NHS England to look at local recruitment and retention, with some targets around that. And that is the piece of work that's the funding, one of the pieces of funding that the primary care leads have been tasked with coming up with a plan to work out how we can best meet, how we can achieve the best outcomes for our individual areas in the ICS in terms of using that funding wisely for recruiting and retaining GPs.
Okay, thank you, Abby. David.
Yeah, I mean, obviously, I would echo both what Mia and Mark have said, but from a more pragmatic point of view of a solution, I think Abby and I have discussed in the past the Opal warning system that they use in Nottingham, and I just wonder if we are looking at a preemptive data collection in a supportive way. I know you do look at the workforce dashboard, but this is more about practices reporting their acute deficiencies in terms of reception staff, nursing staff, doctors, and then trying to pair that with a pool of resource. I know you're looking at the Nightingale model with PCS, but I don't think we've actually got a sort of preemptive Opal type data collection system at present.
No, we don't. We've been down that route several times during the pandemic, and have been unable to get to a position where practices are willing to routinely report that on a daily or weekly basis. So I think if we could have further discussions and get LMC support to actually ask practices to collect that routinely, that would be very welcome.
I think, just to come back on that, I think we would certainly support that and would do that. I think it's about, as we've said before, the carrot and the stick, isn't it? I think the practices have always been reluctant if they feel it's a data collection exercise. I think if they know there is support attached to completing the data, and we had some tangible support that we could offer them, then I'm sure we would support you in getting practices to give that information.
Yeah, I think that's a good idea, isn't it? Especially as we have got the ICS money, and we can perhaps do something practical to support that. It's not routinely collected in the way that the hospitals do it, but we've certainly got some key indicators, one of them being the locums that we can use and go back to previous discussions. Trish, I've got your hand up. Do you want to come in?
Yes, thank you. Trish Edney, I'm the Health Watch rep on the committee. Help me, please. In the past, committees of the CCG have run around chasing the last 100k or 50k to make sure that their books are balanced. Here we are facing a 2 million deficit on one budget. What are the consequences for Sheffield? And, are you going to be running? I can obviously recognise it's pandemic, and I recognise that primary care is under inordinate stress, something that we've never seen before. But also, we've never, in Sheffield that I know, faced a 2 million deficit. So with such consanguinity.
I think that is the really relevant challenge, Trish, and that's why I have taken quite a considerable amount of time to reflect on the best way forward. I think there is a risk appetite question here, because in the past, in balancing budgets recurrently, we have ended up with slippage that isn't utilised both within primary care and across the wider state. I don't think now is the year to bank on generating slippage to balance a financial position. And equally, because we're unclear about what the recurrent position for both the CCG and in particular primary care budgets, it's difficult to recommend a set of actions in the light of that level of uncertainty. And then the final issue, which is one that's really challenging, is that there is a significant amount of additional resources flowing from the national central budgets into the ICS and then into CCGs, where we're being asked to make short-term decisions on funding that could do more good if we understood that over a longer period of time. And so in reflecting this, it's not a risk it's clearly not a risk-averse strategy, what I'm recommending, but equally, I think it's more risky to recommend actions to get back to a balanced position, not knowing what the consequences of that would be. So it's why I've taken the decision over the short term not to recommend any immediate actions. I am flagging up that we will need to take some action over a longer period. I just don't think we have the information or the proposals to do that at this stage. So it's a balance, and that's why I want committee members to understand what I'm asking them to do, because we are collectively taking a level of risk in undertaking this. But I think the consequences of taking a different set of actions will have far greater risks and consequences at the current stage. But I need to know that people are comfortable with that approach.
Thank you.
Thank you. Amir, I don't know if your hand is up again, or is that from before? Are you still there? I'll go on. I just wondered, Victoria, did you want to add anything to the discussion in terms of the wider picture and some of the issues raised with regard to NHSE?
To be honest, I don't think I could really add to what Jackie's already said, really. I just obviously agree with what Jackie said. Thank you.
That's fine, thanks. And it is so unusual, isn't it? We haven't in a place where we've got the annual budget, so that future planning and also other resources that are coming in because of the pandemic. So it's making the maximum use of that. But I totally get what Jackie is saying in terms of the in terms of trying to resolve some of these issues in even the just, you know, after this year, if you like, until we've got greater clarity on what the budget's coming in. And also we've got some clarity over a period of time about what that will be. So unless there are any other comments, I can't see any other hands up, then I would recommend that we approve the recommendations in here, which are about approving the budget set out in the paper, and the work continues to quantify the potential mitigations that may be available to offset the pressure, and consider the final reported financial position at month 3. Jackie, is that okay with you? Did you want to add anything? We have noted some other actions to do with finding out what the current position is and using some other resources.
No,
is that fine? Is that fine with you? Thanks very much. And I just wanted to recognise as well the unprecedented just demand on primary care at the moment, and all sorts of examples that are coming through, and recognition of that across Sheffield by the Director of Public Health and also nationally. So, you know, just thanking primary care for all that work, and also down on staff because of the level of COVID at the moment. So thank you. We'll certainly be coming back to this on other agendas. If we can then move on to the next item on the agenda. So, I'm going to turn the papers over. Sorry about that. So the next item is about is from Richard, and it's an update on the vaccination programme.
No, I think you might have the wrong agenda, Chris.
Oh, sorry about that. Yeah, I have got the wrong agenda. I've buried it. I'm trying to do papers and 2 screens.
I think we've got the digital update next, Chris. From
digital update. Thank you for that, Jackie.
Okay. Good afternoon. I'm Thomas Craig. I'm the Deputy Director of IT Development and Improvement at the CCG. So I've submitted the digital programme update paper for consideration. Hopefully you've had a chance to read that, and I'll just draw out some of the key messages and points from that paper. So we continue to migrate to Office 365. It's probably one of the biggest pieces of work we've got at the moment. So the corporate rollout's underway, and 14 practices have been completed, with 66 left to complete. We mentioned previously at the last meeting that we'd secured some funding for some additional laptops for PCNs. That worked out at 6 additional laptops per PCN. So 12 of the PCNs should have either received 6 additional laptops or have scheduled in, and we've got 3 left to schedule. So that's Township 1 and 2 and City Centre. The Wi-Fi project rollout. So we've requested floor plans so that we can get all the pre-work done. The access points have now been received at Greenworld, and we're just waiting delivery of controllers and switches, and we're expecting those August at the latest now. So that's good news that we can start to move forward and start to push out the corporate wireless. And the last thing of note is for our service improvement plan and feedback, we've added additional functionality to Ivanti, which is our service management, and that's to allow secondary approvers, which is something that we've received as feedback from both corporate customers and primary care. So that's for when people request things. There was just a primary approver, but we've now got functionality to add additional approvers. So hopefully that should make those processes much more smooth.
Okay, thanks, Thomas. Are there any questions or comments for Thomas about the digital update? David.
Yeah, sorry, I forgot to introduce myself. I'm David Savage. I'm Secretary of the LMC and I work as a locum GP. Just while I've got you, Thomas, on the digital update, I just wondered, which we have asked about before, as to what the progress is on ICE printers. We keep getting told that this is an issue relating to STH, but at the present time GPs are still having to buy them, and we can't function without them, and we can't do the blood tests in the way the trust want us without them. So I would be grateful if we could have an update on that either today or at the next report.
No, thank you for the question, David. I'll talk to Abby and we'll bring you an update. We'll send one before the next Pccc, but we'll also cover it in the report as well.
Thank you.
So it does seem to be some significant progress there, Thomas, in terms of being proactive in finding out about some of the issues and resolving them. Has that been, did you want to comment further on that? Because I have had some other really positive feedback about how this has been taken forward.
Sorry, in which element was that? Sorry, Chris.
In terms of the work that you've undertaken to be proactive about resolving some of the issues, and I've had some positive feedback about the progress that's been made over, the last month with regard to this. I just wondered if you wanted to add something about some of the issues that you've resolved.
Yeah, so we've been working closely with Red Centric. We've also started to have cross-technical meetings with other members of the ICS to discuss any issues, and we've been taking additional staff out to on board to meetings with locality managers and the locality leaders groups, and that seems to have been well received. But the field services in regards to pop-up vaccine clinics have been enabling the IT there. We've had some really positive feedback. We're just looking now, working closely with TPP, System 1 provider, to look at any efficiencies and we can make there to speed up clinical systems access, where we've had some reports of slowdowns. So just trying to pick that up and look at our demand analysis as it comes through our desk and through our teams to sort of pinpoint those issues that are having the biggest effect on our user base.
Thank you. I just wanted to recognise that work really, because it so much underpins our ability to progress, and particularly pointing out the in terms of the data with regard to the vaccinations. So are there any other comments or questions for Thomas? I can't see any hands up, so the recommendation is that we're asked to consider the content of the paper. So thanks to you and your team for moving this forward at a significant rate. Thanks. And you're going to get back, was it David, about the issue about the printer? Thanks very much. So moving on to the next item, which is the primary care audit report from Abby.
Thank you very much. This is brought for to make the committee aware of the outcome of the 2020-21 primary care audit. The audit's conducted annually. It's a requirement of NHS England in order to confirm that we are appropriately discharging our delegated responsibilities in primary care. And you will see from the report, I'm pleased to say that this year again, our internal audit provider 360 have given us have given our management of those delegated functions significant assurance. They identified 3 low risk recommendations which we have accepted, and I provided detail in the paper of the approaches we're taking to them. 2 of those are around tightening up the processes for tracking contract variations through the CCG. We've already put steps in place to review how we've tracked those variations historically to make sure that tracker is completely up to date, and then to make sure people have the appropriate training and guidance, on top of which we will put in place some random sort of checking and auditing just to make sure that we are keeping up to date with those. I would say that in the cases that they have identified, those have led to no issues or problems for any of the practices or anyone else involved in that process. It was merely that there was a delay in obtaining the signature, or they weren't recorded appropriately. The other recommendation is about being explicit in papers to this committee that we use the NHS England Policy and Guidance Manual for primary care contractual matters. The committee has already been informed, obviously, that that's the process we follow, and have received information in development sessions previously about certain aspects of the contract management processes we go through. But what we have agreed is that where it's appropriate, we'll specifically reference Policy and Guidance Manual in future papers that we bring, and explain what that approach or those issues are.
Thank you, Abby. Are there any comments or questions with regard to the audit? I can't see any hands up. So just to comment that it is pleasing that the audit, especially we've had so much pressures over this year, and that we have got that satisfactory outcome, and a couple of things to in terms of recording and how we state where the guidance comes from to this committee, which you've got in hand to sort out. So I'll move on to I'll move on to the next item after that. Thank you very much. So we have our other reports is the next item. So I don't know if you wanted to consider items of any other business. I think, Abby, have you got one item of any other business before we look at other reports?
No, not for this. Not at this point, Chris. Thank you.
Okay. Is there anybody else? No, I can't see any hands up for any other business and anything on the other reports. So in terms of feeding back to governance and the key messages to the governing body, I think certainly the governing body will be looking at finance, but there were some specific issues in relation to the primary care that I'm sure, Jackie, you will have on the agenda to report up without me recognising it separately. Is that the case?
Yeah, I think though that the committee has given that some due consideration should be an issue for noting.
Yeah, I think that's important, and also the issues that we've recognised in terms of the workforce and the capacity and the pressures, which we have considered on other times, but that we've looked at and looking at some other ways forward as well. In terms of governance committee, then I think that, I mean, potentially we're collecting more data, aren't we? And I'm having going to be working more closely with Judy with regard to the QAC and quality assurance. So it's just making sure that we keep that alert, both in terms of governance and quality, about some of these issues of workforce pressures, because, you know, that could be an outcome that we don't want to see. So with that kind of looking at risk, so I'd like to refer that up to the governance committee. We haven't identified an issue, but I can just the fact that the impact of it and what it's like currently as well, with a lot of staff missing because of isolation and so on, that I think it should be fed up to the governance committee to look at. Is there anything I've missed, Jackie, in terms of needs to go to governance from this meeting?
I don't think so.
Okay, thank you. Are there any other comments before I close this public meeting? No. Okay, our next meeting will take place in public on the 16th of September between 1:30 and 3, and we intend to do this as a live recording again. So thanks again to everyone on the meeting, and Lucy will close the, if you can wait until Lucy closes the live stream, and then we can just identify the start time for the next meeting. Thank you.
Chris, I can
Lucy
close the
gone.
live stream, so shall I do that now?